Hello and welcome to the third video in the male reproductive pathology section. In this video, I'm going to focus on prostate disorders. We'll look at BPH, prostatitis, and prostate cancer. So a very common problem that males often present to the clinic for is BPH, or benign prostatic hyperplasia. And this is essentially non-cancerous enlargement of the prostate. It does not, importantly, increase the risk of prostate cancer, but interestingly, we can have prostate cancer alongside BPH. So one of the important processes we have to go through in the assessment of BPH is to rule out prostate cancer. This essentially results from hyperplasia of the areas of the prostate around the urethra. So these would be the periurethral lobes, and that would be the lateral and the middle lobe of the prostate. This is going to be different than prostate cancer. That's going to be cancerous transformation of the peripheral zone, so the outer zone of the prostate, and so that it's going to occur in a different area of the prostate. The prostate, as it enlarges, will press on the urethra, and that's going to make it very difficult to pass urine, and that's going to give the characteristic clinical presentation, which I'll discuss here in a moment. Very common, typically begins around the age of 40. 50% of males over 50 are affected, and 90% of males after the age of 80 are affected. So this is something that I have many male patients present to the clinic for options beyond the conventional pharmacotherapy that's used for this. So I'll discuss kind of what we can offer them. The risk factors for BPH would be aging and family history. Basically, all of, again, the ASCVD, atherosclerotic cardiovascular disease risk factors, obesity, type 2 diabetes, hypertension, erectile dysfunction. I often see when men have that kind of metabolic syndrome picture, high cholesterol, hypertension, any sort of history of cardiovascular disease, BPH often is found there as well. Now, a lot of the factors that drive BPH we think are related, the inflammatory factors, to systemic inflammation. So that's probably why they're connected. Medications can worsen the symptoms. Calcium channel blockers used for hypertension, as well as catecholamines, all of these would tend to decrease the ability to urinate, so they would make symptoms worse. Now, BPH, although it's not cancerous, can have important downstream consequences if it's not correctly or properly addressed, and that would be an increase of urinary tract infections, and that's because essentially what happens is the urine is building up in the bladder, and the bladder is becoming distended, and it's pooling there. With urination, the urethra doesn't fully open in the prostate, so you're essentially getting bladder pooling and building up, urine building up in the bladder, and that's going to increase the risk of urinary tract infections. Also, stones forming in the bladder stones, and those could then go through the urethra and then obstruct the urethra downstream. But probably the most concerning are the fact that the urine can actually build up in the bladder and then actually build up in the ureters and start to build up in the renal pelvis, and that puts pressure on the kidneys. That is hydronephrosis, and that can compress the parenchyma, the tissue of the kidneys, and that can induce renal failure. So that can definitely impact kidney function. So that's probably the most serious downstream complication of BPH. The causes are unknown. There's a lot of suspects I just mentioned. So one of them is diet. So we see that with increased animal proteins, saturated fat, decreased vegetables, anti-inflammatory foods, that there tends to be increased risk of BPH. Environmental toxins, as I mentioned in previous video, are a possibility there too. And then hormones, and again, some of the environmental toxins act as xenoestrogens, so they have estrogen-like effects. There is, we think, certain neuroendocrine factors that increase the incidence of BPH. So testosterone promotes prostate growth, but the interesting thing is that, again, males between 20 and 30 have the highest testosterone levels, and they have the lowest BPH levels. And it's a male, as they get older and their testosterone levels drop, their BPH levels go up. So there's definitely not a clear correlation with testosterone. And testosterone supplementation doesn't seem to worsen BPH. Again, if there's any underlying prostate cancer, we have to be very careful about testosterone supplementation in a patient with BPH. We do know that BPH risk can be increased with low serum testosterone. So it seems like that's one factor, is maybe low serum testosterone, but higher dihydrotestosterone. So DHT in particular, remember this is the active form of testosterone that is converted via 5-alpha reductase. The DHT definitely increases prostate growth, and that DHT levels seem to go up with age, although they're still high in a young man. So this alone probably isn't a factor for causing prostate growth. But one of the therapies that is used medically are the 5-alpha reductase inhibitors, and that's used to try to decrease the level of DHT to try to decrease the stimulus on prostate growth. One emerging hypothesis is that it's the level of estradiol that goes up in older men. And that's because of increased aromatase levels. And as they go up, we see an increase in BPH risk. So I put a question mark there because it's still a hypothesis, but there is a pretty broad discussion about that in the literature. There's other factors, HPA axis dysregulation with high cortisol, as well as low melatonin, could all be factors. In Chinese medicine, I'll just mention the kidney, spleen, and liver channels all are thought to nourish the prostate. So kidney yang deficiency, which essentially would be the low androgen picture. Spleen yang deficiency would be kind of like a low pancreas, but also insulin dysregulation picture. Blood stasis, that would be endothelial dysfunction. And then damp heat, that's also listed as a pattern that can cause BPH. And again, in the Chinese medicine thinking, we don't really focus on BPH. We look at patterns of neuroendocrine dysfunction. So damp heat pattern would be more of an inflammatory pattern, and that's going to be more associated with patients with prostatitis, not so much BPH. But I think it's interesting that one of the main patterns for BPH in Chinese medicine is low androgens. And that's often how I approach BPH clinically. So I'll talk about that here in just a moment. What's the clinical presentation? Well, the key word here is LUTS, lower urinary tract symptoms. So patients will present with LUTS, and that can be either problems of urine storage, so that'd be problems of urinary frequency, urgency, or nocturia, involuntary urination or urge incontinence, or problems with voiding, and that would be urinary hesitancy. They just can't get the urine stream started. Weak streams, they really have to strain to get the urine out. Leaking after the end of urination, dribbling, and then dysuria, painful urination. That's going to be a lot less common with BPH. So that's pretty much rarely present unless there's maybe some underlying infection or passing bladder stones or something like that going on. Bladder outlet obstruction, we use the abbreviation BOO, can also be caused by BPH. So as the prostate enlarges, it squeezes off the urethra, urine builds up in the bladder, and so we can get abdominal pain from that, a feeling that after urination, there's still fullness or pressure in the lower abdomen. That's from a full bladder. And when the bladder, gets to be over 250 milliliters with urine, that's when people can begin to feel pressure in the lower abdomen. When it gets above 500 milliliters, that's when we start to really be concerned. And we'll see that one of the treatments for more advanced BPH is actually to have a man put a catheter through the urethra up into the bladder to drain that every day. Otherwise, we might start to see overextension of the bladder, and again, that can increase the risk of hydronephrosis. Frequent urination, acute urinary retention, slow urine flow, and nocturia are also signs or symptoms of bladder outlet obstruction. So that would be the classic clinical presentation of BPH. So how is BPH assessed? So this might be helpful to read alongside with something like UpToDate. And some of these notes are derived actually from UpToDate. So it's important to differentiate, first of all, BPH from other causes of lower urinary tract symptoms, or LUTS. And so we need to do a proper differential diagnosis. So the DDX for LUTS, first of all, would involve either urologic causes, so BPH would be one, but prostate cancer, bladder cancer, prostatitis or chronic prostatitis, and we'll talk about that here coming up, something called chronic pelvic pain syndrome in males, interstitial cystitis, overactive bladder, or urethral stricture. These would all be urological causes of LUTS, but there could also be neurological causes like Parkinson's disease, any sort of neuropathy like diabetic peripheral neuropathy can also cause LUTS. And then trauma, congestive heart failure can cause LUTS. Renal disease can rarely cause LUTS. Endocrine, long-standing uncontrolled diabetes, which can cause neuropathy, and then polydipsia, and any of those disorders can cause LUTS. So we want to just do a quick differential of those. Probably the biggest important ones would be, prostate cancer and bladder cancer would be the ones to kind of look at. So that's the first thing, is just kind of getting the history and gathering all the LUTS and the BOO symptoms. So looking at urinary frequency, urgency, any nocturia. Again, any forced or decreased stream, straining, intermittent stream. Using a couple of symptom scores, which are very helpful. You can download these from the internet. So probably the one I use the most is the IPSS, International Prostate Symptom Score, and that's just a questionnaire for the patient to get a baseline of all of their urinary symptoms so that we can establish that, and then we can use that over time to assess their progress. We can gather their other medical history, all their medications, family medical history, past medical history, and so forth. Physical exam really includes the digital rectal exam, and then a pelvic, perineal, and abdominal exam, and then a neuro exam to rule out any neurogenic causes of LUTS. So the DRE, kind of illustrated in this picture down here, is done with the patient usually lying on their side, left lateral decubitus position. A gloved finger is inserted, usually with lubricant, and by pressing in through the rectum, we can actually feel the backside here of the prostate. And so we want to look for the fact that the prostate normally is about the size of a walnut. The normal sort of firmness or texture of the prostate should be about the same as if you press on your thenar eminence on your hand. That's that big bulge where your thumb muscle is. It should be about that same consistency. So that's typical kind of for a healthy prostate. And the prostate has two lobes. There's a little seam down the middle, a little sulcus, and normally you should be able to feel that sulcus. So a healthy prostate should, again, be about the size of a walnut, which is about, if you look at the index finger, that's about 2 or 3 finger breadths. So that's a typical prostate size, and we can actually chart that in the notes. The prostate is 2 to 3 finger breadths in size. If it's over 3, that generally indicates prostate enlargement. And it should be, again, firm, about the same firmness as the thenar eminence. It should be non-tender, so when you press on the prostate, it should not hurt. In BPH, typically, the prostate will not be tender. It'll be tender, though, in prostatitis. And so that's one important differential there. We should feel that the prostate is symmetric. So in other words, if you look at that median sulcus, on either side of that, the prostate should be even. There should be no abnormal lumps or nodularity felt on the surface of the prostate. That's going to be a lot more indicative of prostate cancer. This is using DRE is not really a precise tool for measuring the volume of the prostate. What we need to use there is the transrectal ultrasound to do that appropriately. But this is helpful for just doing a baseline assessment. So with BPH, we should typically feel a symmetric, smooth, and enlarged prostate. So that's the typical BPH finding. With prostate cancer, usually the prostate feels like there's nodules, it's asymmetrical, and it feels very hard. So that's typical prostate cancer findings. And then in prostatitis, it's going to be painful. So DRE can be very helpful for differentiating the different types of prostate disorders. So that's the first physical exam we're going to do. Again, a neurologic exam and a pelvic exam could be helpful as well for just assessing the kind of overall musculature and so forth. I often will do an abdominal exam where we're going to palpate over the bladder. Just be careful if a lot of men are not voiding appropriately. That will really cause the urge to urinate. So just be a little cautious with that. In terms of labs and imaging, going to do a urinalysis to rule out any urinary tract infection and possibly get a urine culture with that. Another test that can be used is PSA. Now, this is controversial. I'll just say that PSA, or prostate-specific antigen, is usually not recommended for the diagnosis of BPH. It's used primarily as a screening tool for prostate cancer. That said, it's very difficult. There's a lot of different guidelines right now around BPH. It's very controversial because what we found is that with the older guidelines, a lot of men were being over-tested, and the main test we use for prostate cancer is prostate biopsy. Well, they actually put a biopsy gun up here, and they shoot cores through the prostate, gather that, and then examine that microscopically. As you can imagine, that's a very invasive, painful, uncomfortable procedure. And what they were finding is that a lot of men with elevated PSAs were getting unnecessary prostate biopsies. And so there's a lot of controversy about what PSH ranges are appropriate. And I'll talk about that in more depth with the prostate cancer discussion coming up here. But basically, when the PSA levels get above, normal levels will be between 0 and 4 nanograms per deciliter. When they get above 1.5, that indicates the prostate volume is over 35 milliliters, so it's indicating enlargement. And the prostate levels above 4 or above, PSA levels, that really is going to trigger a prostate cancer workup. So we can use prostate cancer PSA levels to kind of tell us, okay, do we need to go further and do the prostate cancer workup? The problem with PSA is it's very nonspecific. It's elevated for a number of reasons. Trauma, if a male, for example, rode their bike to the clinic that day and they got the PSA test, it could be elevated. It could be elevated because of prostatitis. It could be elevated because of a lot of these other issues. So it's very nonspecific. So we have to really think about other factors that might be raising it. So what we typically do is if we see an elevated PSA in the clinic, under 10 usually, we're going to get a repeat. Even over 10, that can often indicate either cancer or trauma. So we want to repeat that PSA test, usually within a few weeks, to see that it's not just an erroneous value. But if we get 2 or more consistent elevated PSAs over 4, that's going to prompt us to do a prostate cancer workup. And I'll talk about that here coming up here. So that's PSA testing. Another test that's used for BPH is post-void residual volume, Pvrv. Now, this is not typically done in primary care settings. This usually requires an ultrasound of the bladder. And so this is going to detect urinary retention and how much retention there is. We start to get really concerned, again, when the bladder is over 250 milliliters, gets up to 500, then we're really concerned. But 250 is kind of our cutoff there. And that's done with, again, bedside ultrasound, or you can have a man urinate and then immediately after do a catheter, put a catheter in, and then collect how much urine comes out. And that can measure the post-void volume. So this is something that's recommended for any patient you suspect that has BPH. However, it's going to usually need referral to a specialist to kind of evaluate this. Other tests can be done, but they're not done routinely, and that would be the transrectal ultrasound of the prostate to determine the prostate volume. You know, in the older sources and up to date, it's saying this is not routine. I see a lot of physicians, though, ordering this because it's not a bad way to kind of get an estimate of prostate size. It's just, you know, not the most comfortable test. And so if we don't have to order it, that's why we typically don't want to. Kidney function tests would be ordered if you suspect any degree of hydronephrosis. A routine CT scan, unless you suspect prostate cancer, is not recommended. And then cytoscopy, and that's where we put the scope up the urethra to look at the bladder, is only going to be indicated if we suspect urethral stricture or bladder cancer and so forth. So those would be more specialized tests in more limited circumstances. So that's the basic workup for BPH. So how do we treat BPH from a more integrative setting? Well, we want to use a therapeutic order. For most symptomatic patients, we're probably going to need to jump to level 4 in therapy, especially if there's any degree of bladder outlet obstruction and filling of the bladder over 250 milliliters. That's bladder retention. Now, a couple of the indications for referral. So if we see a patient and we see the following, we're going to need to refer them out urgently. That would be severe symptoms or pain. Men that develop these symptoms less than 45 years old, that's going to be more concerning. Abnormality, again, that you might feel evidence of prostate cancer, etc., on digital rectal exam. Any degree of hematuria. Elevated PSA above 4 on repeated measurements. Dysuria, again, that could indicate bladder cancer. Incontinence, neurological diseases that you might need to have proper workup for. And then a post-urinary retention, the post-void residual volume, over 250 milliliters or a palpable bladder on a lower abdominal exam. So those really are indicating this patient needs to be catheterized. They're going to need to be given instructions on how to do that properly. Or if you suspect any other urological disease. So those would all be indications for referral for BPH. So let's look at the therapeutic order for BPH. So again, most patients that are symptomatic, and again, with any evidence of bladder outlet obstruction and urinary retention, we're going to need to think about level 4 therapies here. So let me go through those first. So level 4 therapies, usually the medications would include the primary medication that most patients are started on would be the selective alpha-1 blockers. So the most common initial treatment. And remember, alpha-1 receptors in the prostate are receptors for norepinephrine, epinephrine, and they're going to cause urinary retention. So by blocking alpha-1 receptors, that's going to improve urination. So there's a small to moderate symptom relief with these. The adverse effects of alpha-1 blockers would be hypotension systemically, erectile dysfunction, and nasal congestion. And that's because they block the alpha-1 receptors in the nose, and that causes vasoconstriction. The classic alpha-1 blockers for the prostate will be tamsulosin, Flomax, terazosin, Hytrin, and doxazosin, Cardura. So those are very commonly prescribed for that. For longer-term treatment, and this was the older treatment for BPH, we use the 5-alpha reductase inhibitors, and those again will inhibit the production of DHT in the prostate, and that would be finasteride, Proscar, or dutasteride, Avodart. So those can be added on with the alpha blockers, although I typically see urologists and others just prescribe the alpha blockers primarily for BPH. For BPH with erectile dysfunction, that's where the PDE5 inhibitors are also added in as therapy, and that would be the Viagra or Cialis. Other therapies here in level 4 would be self-catheterization, and that would be to relieve the bladder pressure. The problem with the catheters obviously would be the increased risk for urinary tract infections. So I've had some patients where they actually need to catheterize every day or every other day. And one of the true benefits I've seen of therapy, and this is with adding in level 1, level 2 therapies, or with any shrinkage of the prostate, is going to be an improvement in that. So I now have a patient who used to catheterize every day. Now he only has to maybe once a month or so do a self-catheter. And patients have to be trained in how to do this appropriately, usually shown the whole technique. Now, the more advanced therapies for BPH would be surgery. And that would be either a transurethral resection of the prostate, the CHIRP procedure. You can almost think of that as a rotor-rooter for the prostate. So a specialized instrument is inserted through the penis, through the urethra, and it actually mechanically breaks apart the prostate tissue surrounding the urethra there. As you can imagine, that's going to result in a lot of bleeding, a lot of discomfort, and so forth as that heals. There's a newer procedure, and that uses a laser to vaporize the tissue. That's photoselective vaporization, PVP. So that's become a little bit more common as more and more centers have that equipment to do that. Rarely there's an open prostatectomy where the prostate is removed, and that's a more invasive surgical procedure. That can result in a lot of problems, damage to the nerves that innervate the penis, for example, which will result in permanent erectile dysfunction and so forth. So that's reserved for more advanced cases. So those are the level 4 therapies that can be used for BPH. I have a lot of patients with more mild symptoms where we're not so worried about the urinary retention. They're still able to urinate enough to void properly, where we can focus really on reducing some of those risk factors for BPH. So focusing more on a whole food, healthy diet, so high vegetable protein, low carbohydrate, low animal saturated fats, increase omega-3s. Pumpkin seeds are very high in zinc, together with the beneficial fatty acids. Limiting alcohol intake. Soy has a protective effect on prostate BPH, and then limiting coffee intake. Coffee can increase the lower urinary tract symptoms. So just because of the diuretic effect, make that the symptoms more prominent. Exercise will increase blood flow to the urogenital region, so that can be helpful. And also, they help reduce insulin resistance, and then it helps with obesity reduction, which is a risk factor for BPH. Lifestyle, sleep hygiene in particular, very important here. And then stress reduction might be something to look at as well. So that'd be level 1 therapies. Level 2 therapies would be using micronutrients and maybe herbal therapy. So there's unclear evidence, but it's commonly used in a lot of the products on the market for BPH, using zinc up to 35, 45 milligrams a day. And we have to be sure to add maybe a couple of milligrams of copper if that's taken for more than 6 weeks. Glycine, 200 milligrams a day. Glutamic acid, 200 milligrams a day. And alanine, these are 3 amino acids that are commonly used for BPH. And then vitamin D. Herbal therapy, there's mixed evidence for saw palmetto, pygeum, pumpkin seeds, nettle root, cernilton, which is a pollen extract. So you could do searches on PubMed for that, and you can see what the latest evidence is for those. I find that these are often all combined in products, and they can actually have a beneficial effect for patients with mild to moderate BPH symptoms. But again, we always want to monitor to be sure they're not having urinary retention that could eventually cause hydronephrosis. All right, so that's the therapeutic order and the treatment options we can give our patients with BPH. So the next major set of conditions that involve the prostate would be prostatitis, and that's inflammation of the prostate. And that can be either acute or chronic. And the chronic can be either bacterial or abacterial, so it gets a little bit more complicated. So let me talk about acute prostatitis here first. This is a bacterial infection of the prostate. Patients will present looking like they have an infection. So they have pain in the low back, perineum, chills, fever, urinary frequency and urgency, nocturia, dysuria, body aches. And this is commonly caused by E. coli. That's the most common cause of urinary tract infections in females, and this comes from the gut. Klebsiella, Proteus, Pseudomonas, Staph aureus, Enterobacter, etc. These are all common agents causing bacterial prostatitis. We're going to see on a CBC usually increased white cell counts. The urinary bacterial cultures will be positive. Urine leukocytes will be positive on dipstick. PSA is going to be elevated usually. And this might actually require blood cultures if a patient really looks septic and sepsis is suspected. If there's an abscess which can form, that can cause acute urinary retention. That's usually diagnosed with the transrectal ultrasound, the TRUS. In these patients, importantly, we should not perform a DRE especially with any sort of prostate massage. Prostate massage is where you do the DRE, you massage the prostate to try to expel fluid. So that can be analyzed, so if there's pus or something. But this can actually cause sepsis, so we do not want to do that in these patients. This is considered a medical emergency. Patients will usually need to be hospitalized if they're severely ill, and they might need IV antibiotics, and they might need to be catheterized. They can develop sepsis, and this is most common in immunocompromised patients with HIV/AIDS. The antibiotics typically are given for 2 to 4 weeks. Again, they might be given intravenously. The difficulty with the prostate is there's a capsule around it and it gets very poor blood flow. So it's difficult to get the antibiotics via the bloodstream into the prostate. But typical agents would be Cipro, the TMP SMX, the Bactrim, doxycycline, and the fluoroquinolones, and they're given in combinations often for acute prostatitis. Prognosis is usually good, but some of these patients might progress on to developing chronic prostatitis, and that gets a lot more difficult to treat. So that's acute prostatitis considered a medical emergency. Chronic prostatitis is relatively rare, less than 5% of cases of prostatitis. Pain is more variable. We still see bacteria present in the urine and white cells in the urine. We get intermittent lower urinary tract symptoms, and usually this is from E. coli that's formed biofilms within the prostate, and also stones can form in the prostate because of that. The CBC is usually normal here, but the bacterial cultures will be positive. Urine leukocytes are positive. If a semen analysis and culture is done, that might be positive. Here, prostatic massage can be a diagnostic tool, and the prostatic fluid is cultured, and there might be bacteria in that. And the PSA is usually elevated here as well. This is usually 4 to 8 weeks of outpatient antibiotics for quinolones, tetracyclines, macrolides, quinolones, etc. Alpha blockers might be used for the urinary tract symptoms. And then prostate massage sometimes is indicated to try to get fluid expressed through the prostate to help it discharge. That's controversial. That can be challenging for patients presenting every other week wanting a prostate massage. So that's something that's not typically recommended, but some of the older sources indicate that could be beneficial. The relapse rate is very high with chronic prostatitis, and usually we're going to need a lot of combination therapies. And I'll talk about some of the potential herbal options here in just a moment. Probably the most common form of prostatitis that I've seen many males present for in the clinic is what is now called chronic pelvic pain syndrome. It used to be called chronic non-bacterial prostatitis because if you culture the urine, culture prostatic fluid, everything like that, it's negative for any bacteria. This typically is divided into inflammatory and non-inflammatory types, although there's a lot of crossover between the two. This presents with chronic pelvic pain plus lower urinary tract symptoms that happen for more than 3 months. There is, again, no evidence of bacterial infection, and very common, up to 95% of all cases of prostatitis. And it affects up to 2 to 6% of all men. It's unknown cause, and the symptoms tend to wax and wane. I've had many male patients present with this. It's something that is not well treated with the conventional level 4 therapies. So this is where we can start to think about a lot of the level 1, level 2 therapies to help support them. In the inflammatory type, typically there is pus that's present in the prostatic secretion. So there's no bacteria, but there's pus. So of course, some people suspect there's just bacteria that we haven't been able to detect. But the non-inflammatory type has no pus, no bacteria, and that's the type I've seen most commonly in the clinic. So maybe there is some sort of intercellular bacteria that we don't know of. It's very difficult, obviously, to assess that without doing some sort of prostate biopsy, which is never done for these conditions. With interstitial cystitis, if we have that on top of chronic pelvic pain syndrome, that is called urological chronic pelvic pain syndrome, UCPPS. And the treatment there is usually using anti-inflammatory substances like quercetin. There's some evidence for the cernilton, the flower pollen extracts, being helpful there as well. Various hypotheses as to what causes this. So pelvic floor dysfunction, HPA axis dysregulation, neurogenic inflammation, central sensitization. One of the most important therapies I've seen that's helpful for this is actually nervines. So that's probably because of an overactivated sympathetic nervous system that tends to hypersensitize pain perception in the central nervous system. So nervine herbs could be one option. That would be things like passion flower, skullcap, scutellaria, lavender, motherwort, albizia, and ziziphus, etc. There's no definitive assessment for this, but we need to differentiate chronic pelvic pain syndrome from BPH, bacterial prostatitis, overactive bladder, and prostate cancer. And so we might use, CBC, urinalysis, Potentially prostatic fluid assessment. Again, I put a question mark there because it's not a standard therapy to use. Usually we can get a pretty clear picture of this doing our standard workups, history and physical, to kind of narrow it down to chronic pelvic pain syndrome. No clear data on treatment. We definitely think stress reduction using nervine herbs, sedative adaptogens to downregulate the HPA axis could be helpful. Massage to the pelvic floor to different trigger points, even intrarectal massage has been proposed as potential therapies there. Acupuncture therapy, acumoxa, herbal medicine, again, nervines. Occasionally, I've seen males respond well to phytoandrogens, assuming this is a low androgen picture. So that's another group of herbs to maybe think about, together with stimulant adaptogens to increase adrenal DHEA. That has a very strong anti-inflammatory effect. Medications, again, alpha blockers might be considered. Antibiotics are controversial for chronic pelvic pain syndrome. NSAIDs are sometimes used, and the rest of these are kind of off-label, but maybe prescribed for this, like gabapentin, amitriptyline, and then even benzodiazepines, just to relax the central sensitization for pain. Probably not a good idea to go with these long term. They all have their own individual problems, especially the gabapentin and the benzodiazepines. The prognosis is improving with new therapies, but this is still a very frustrating problem for a lot of males to deal with. And I talk about it at length here because it is something I commonly see presenting to more alternative or functional or integrative medicine practices because it's not something well addressed by the conventional standards right now. So that's chronic pelvic pain syndrome. There's a much less common form of prostatitis called asymptomatic inflammatory prostatitis, and that's where we get inflammation of the prostate. There's no evidence of infection, but there is leukocytosis in the urine. And what we usually do is rule out other conditions. Really, no treatment is usually required for this. Sometimes antibiotics are given, but there's no evidence. So this typically is a patient who maybe on urinalysis just has some leukocytosis, no pain, no lower urinary tract symptoms, no bladder outlet obstruction, nothing like that. And so usually we typically might give supportive therapy for that, but no additional therapy is needed. All right, so that is the major types of prostatitis that we need to be familiar with. Finally, in the prostate disorders here, I need to talk about prostate cancer. So this is adenocarcinoma of the prostate. Adenocarcinoma, remember, it refers to a glandular cancer, and the prostate is mostly glandular tissue. It's most common it arises in the peripheral zone of the prostate. In terms of BPH, remember, it's the zone around the urethra that is most commonly enlarged. Here we're seeing cancerous growth in the peripheral tissue on the outsides of the prostate. It's the most common non-dermatologic cancer in men over 50 years old in the US. So the most common cancer and cancer death cause in men is lung cancer still, but prostate cancer for males over 50, this is a very common cause. There's about almost 200,000 new cases and about 32,000 or so deaths in the US. That was in 2019. And the incidence increases with each decade of life. The lifetime risk is about 1 to 6, and there's a 75% of prostate cancers are diagnosed in men over 65. So it's really a cancer that increases with age, and the risk is highest in Black men. The overall 5-year survival rate of prostate cancer is high. It's over 98%. Most men are diagnosed, first of all, with localized disease, so before it metastasizes. And secondly, most men are more likely to die with the prostate cancer than from the prostate cancer. So usually they die of heart disease or some other reason. And then if an autopsy is done, on autopsy they find prostate cancer, but it's not the prostate cancer that killed the male. So that's going to be the most common thing. However, in some, it's the prostate cancer, which is the primary cause of death. Other forms of prostate cancer, which are more rare, would be sarcomas, primarily in children, and squamous cell carcinomas or ductal transitional carcinomas. So when we say prostate cancer, again, we usually refer to adenocarcinoma, but if a patient presents to your clinic saying they have prostate cancer, you might want to be clear about, what kind of cancer do they have there. The clinical presentation, usually this progresses slowly. So there's time typically with prostate cancers to figure out the right therapeutic approaches. Unfortunately, though, it rarely causes noticeable symptoms until it's quite advanced. And then, unfortunately, the prognosis drops off considerably. Once the cancer grows and spreads, it can cause bladder outlet obstruction. So that's going to cause the typical symptoms of straining to urinate, weak or intermittent stream, sense of incomplete emptying, terminal dribbling, and possible renal failure due to hydronephrosis. There could be hematuria or hematospermia, so the blood in the semen. Other would be signs of malignancy would be when the cancer has spread. It most typically spreads to the pelvis, to the ribs, and vertebral bodies, so to the bone. And then you might see it in the pleura. So a patient might present with bone pains, pathological fractures, spinal cord compression, weight loss, weakness, anemia. They might mistake actually hip pain for osteoarthritis, when in reality it's actually metastasis from a prostate cancer. In the more advanced stages, you'll see things like pleural effusion from the prostatic mets in the pleural tissue, and then liver mets as well. So the goal is to obviously detect this early enough to prevent its spread. That said, we have to be careful about over-testing men for prostate cancer because, again, the primary assessment tools I mentioned before is a prostate biopsy, and that is a very invasive kind of treatment. Okay, so that's the typical clinical presentation. What are the risk factors? Well, non-modifiable risk factors would be age. So prostate cancer is very uncommon in men under 45. Having a family history of a male having prostate cancer. Ethnicity, most common in Black patients, more so than in white or Hispanic men. And then genetics, having BRCA1, BRCA2, HPC1, etc. These would all increase the risk. That by no means a man will get prostate cancer, but it might increase his risk. We do know there's a connection with diet. So having a high red meat animal fat diet, low in omega-3 fatty acids. However, there is a trial, the PCPT trial, which actually showed an increased risk in males with higher blood levels of omega-3 fatty acids. That was an interesting finding. That by no means, though, says that supplementing omega-3s in the diet and whatnot would cause prostate cancer, but that's something to consider. Having a low vegetable diet, increased dairy increases the risk. Low lycopene containing foods like tomatoes, having low tomatoes, that sort of thing, potentially increases the risk. Soy is protective, so low soy diets might increase the risk. Alcohol has mixed data. Coffee tends to decrease the risk of metastatic prostate cancer in males. This is one of the things where we used to demonize coffee for having all sorts of negative health outcomes, but now we find that coffee actually has all sorts of benefits, and that's probably because of all the polyphenols in coffee. So we're finding that it actually protects the cardiovascular system, it protects the heart, protects the prostate and spread of prostate cancer and so forth. High-dose multivitamins, interestingly, there's been studies connecting different nutrients there to an increased risk of prostate cancer. So this is where oversupplementation of these nutrients might actually increase cancer risk. We do find, though, that potentially having elevated selenium or proper selenium levels might decrease the risk. Usually zinc, oral zinc seems to be ineffective at preventing cancer growth or spread, but we do think that zinc decreases the growth of cancer, and that's from getting dietary zinc or normal levels to the diet. And then potentially low vitamin D might increase the risk of prostate cancer. So very sort of nebulous here on dietary recommendations, but again, generally emphasizing a whole foods, nutrient-rich, anti-inflammatory diet is helpful. Exercise appears to decrease the risk of advanced prostate cancer. Cigarette smoking increases the risk. Vasectomy, that's always a question people have. Will that increase my risk of prostate cancer? It's unclear, but it's thought to have little risk. And then we think that more frequent ejaculations, interestingly, might decrease the risk of prostate cancer. The evidence is a little sketchy on that. Different endocrine factors might increase the risk. So obesity, insulin resistance, we think are associated with increased risk. Now, testosterone, dihydrotestosterone, estrogen levels do not increase risk, but the testosterone replacement for hypogonadism also doesn't increase risk. But once cancer has formed, androgens do increase the growth of prostate cancer. So we don't think these hormones cause prostate cancer. In fact, low levels might increase the risk for prostate cancer, but definitely if there's cancer, giving testosterone will increase the cancer growth and spread. So we have to be very careful about that. A lot of environmental factors, dioxins, bisphenol A, etc., also we have found increase the risk of prostate cancer. Here is a picture over here showing the lymph node spread. This is typically how prostate cancer spreads through the lymph into the different parts of the body. But again, it's going to invade local bone and typically start here in the pelvic region. Okay, so that's a little bit about the clinical presentation and some of the risk factors for prostate cancer. So let me say a few words here about assessment of prostate cancer. There's really four aspects of assessment. One is screening, and that's where we're going to want to, do proper screening for males, and that's going to involve usually a digital rectal exam and PSA testing. The next step would be biopsy, and that's going to be a transrectal ultrasound guided needle biopsy. Usually that's taking several cores, up to 12 cores from the prostate. Grading by histology based on what we find in those cores, and that's assigning a Gleason score or a grade grouping score, and then staging using CT and bone scanning to see if there's any metastases. So all of these are aspects of prostate cancer assessment. The Gleason score, the clinical stage, and PSA level are going to all help predict the pathological stage, the prognosis, and the treatment options. So for screening again, DRE, we're going to look for any induration, that's hardness, or nodularity, that can suggest cancer. We're going to have to keep in mind that early prostate cancer is usually not palpable, so this is not a very sensitive test. The cancers palpated by DRE are usually large and they extend through the capsule itself. So just know that about DRE. PSA is kind of the main screening tool we have. It's controversial because there are many false positives, and this can result in over-testing. So the guidelines are really mixed depending on where you go. Usually increased PSA is usually going to be present in prostate cancer, but it's not specific to prostate cancer. Usually it's unclear if the screening is actually decreasing morbidity or mortality. So you get more tests done, but does that decrease overall the morbidity or mortality from prostate cancer? That's the question. It may decrease the life quality in treatment of asymptomatic cancer. So some men might be overtreated from that. So we got to weigh all these risks versus the benefits of PSA screening. So that said, let me just talk a bit about the guidelines here. So there's no real agreement from the guideline committees. If we look at the the United States Preventative Services Task Force, USPSTF, they really recommend for men between 55 and 69 to use what's called shared decision making, where you discuss all the risks and the benefits with your patient. If a male's over 70, we usually don't screen. So that's when we kind of cut off screening. There's no screening if life expectancy is also less than 10 to 15 years, because it's going to take at least that amount of time usually for early stage prostate cancers to grow to be life-threatening. We usually start screening annually in men over the age of 50. So get a baseline PSA at 50. Screen early if there's a positive family history or if a patient is a Black patient. Usually we start maybe at 45, even age 40, looking at PSAs in those cases. If there's an abnormal PSA, then the next step is going to be the transrectal ultrasound guided needle biopsy. So what are the different thresholds for PSA? The first thing to remember is an elevated PSA. We always need to get a repeat PSA within maybe 3 to 4 weeks, up to 6 weeks, to make sure this wasn't just from a trauma or some other cause causing elevated PSA. Typically, PSAs that have been confirmed, maybe a couple of readings to be over 10 nanograms per milliliter, that's a that's a pretty sure kind of threshold to indicate the need for biopsy. So that needs to be referred for biopsy. If the PSA is between 4 and 10 nanograms per deciliter, then the next step is to check. So what I do is I get a baseline PSA. Let's say it comes back at 5 or 6. I'm going to remeasure that again within 4 to 6 weeks. And at that measurement, I'm also going to get a free to total PSA ratio test. And it turns out if the ratio is less than 10%, in other words, if we have a lower free PSA, that's going to be more indicative of cancer. So I'm going to send that patient for biopsy. If the ratio is greater or equal to 25%, that's more likely to be PPH. So we can maybe watch and wait that case. Now, the next thing I'm going to look at is Psa velocity. So we're going to recheck that PSA usually twice a year. And if we see a rise of 0.75 nanograms per milliliter a year, that's indicating a more rapidly growing prostate, and that's going to be a prompt for biopsy as well. So get a baseline PSA, recheck it if it's elevated, if it's above 4, within 4 to 6 weeks. Also get the free total PSA. If the ratio is 25% or more, then I'm going to follow the PSA velocity. If I see that going up, then I'm going to refer for the biopsy. So that's the typical decision making we use for prostate cancer assessment. Again, a PSA under 4, we're going to probably use shared decision making, watch and wait before sending on for biopsy in those cases. Now, another test I'll just mention here is the Psa density, and that's the ratio of PSA to prostate volume. The thing there is you'd have to get a transrectal ultrasound to get an accurate prostate volume measurement, but an increased PSA with a small prostate volume is going to be more worrisome for cancer, and especially if it's over 0.15 nanograms per milliliter. So that is a PSA density test. If you find on the DRE that there's nodularity or any abnormality, then by all means send for biopsy. In Europe, they use a prostate MRI to help with this. It's not commonly used in the US, but that could be helpful as well for examining the prostate. And then the transrectal ultrasound could be useful for assessing prostate volume, as I mentioned, but also can detect maybe irregularity, asymmetry, things that would be more indicative of prostate cancer in those cases. There are other PSA tests I'll just mention, and so if you read a lot of the literature out there, it gets very complicated. There's something called the 4K score, the PCA3, the Select MDX. These are currently not recommended by the major guideline committees because there's not enough information on how accurate they are. But we might see in the coming years with more data that these become more standardized tests. So this is complicated. It's not an easy decision. If you feel uncomfortable with PSA testing and working through all this, then by all means just refer a patient to a urologist for the proper workup and assessment. Again, we want to always differentiate LUTS with these other causes. So patients presenting with LUTS, we have to think about cancer, the prostate or bladder, prostatitis, BPH, interstitial cystitis, overactive bladder, urethral stricture, neurological problems, and trauma. All right, so that was the kind of screening test, DRE and PSA. Now, once let's say a biopsy is done, the next thing that happens is a patient will be given a Gleason score based on the results of the biopsy. So usually we're going to look at 2 samples, and each is scored on a score of 1 to 5. So the total score will be 10 on the Gleason score. The lower the score, the better. So scores less than or equal to 6, that means a well-differentiated cancer, usually slowly growing. And in most cases, a lot of those cancers we could probably just watch and wait and follow with time versus having to use aggressive therapy. A Gleason score of 7 means a moderately differentiated cancer, and then 8 to 10 has poorly differentiated. These are the most aggressive and need more active treatment. The WHO in 2016 proposed a new classification system called the grade group, and there's groups 1 to 5. Same thing, lower the score, the less aggressive the cancer. The final step is if a patient has especially a Gleason score of 7 or above, we're going to want to try to stage the cancer. So using transrectal ultrasound, abdominal pelvic CT or MI, needle biopsy of lymph nodes, and then serum alkaline phosphatase, which might indicate the evidence of bone metastases. These would all be part of staging systems. Grading and staging is something that I refer to the urologists and the cancer specialists to do. So that would be my recommendation, is to refer that out unless you really focus on that in your practice to do those. Now, the risk of cancer spread is very low with a stage less than or equal to T2A, a Gleason score less than or equal to 6, and a PSA under 10. There's intermediate risk of spread if the stage is T2B, Gleason of 7, PSA is over 10, but less than 20. And then a high risk of spread with a stage more than T2C, a Gleason score above 8 or above, and a PSA over 20. So that gives you a rough idea of, again, how aggressive one needs to be with the different treatments. So that is a overview here of the assessment methods we use for prostate cancer. Finally, treatment for prostate cancer is really going to be guided by our PSA levels, our grade and stage of the tumor, the patient age and life expectancy, and whether or not if they have any coexisting disorders. So the goal of the therapy can be watchful waiting, and that's different than doing nothing. That's with a palliative intent. Active surveillance with a curative intent. Local therapy aimed at curing, so that'd be local treatments, and then systemic treatments aimed at limiting tumor extent. Once the tumor has metastasized, usually there is no cure at that point, but it's a question of maybe slowing down the metastases and extending the patient's life expectancy. The prognosis is going to be very good for most patients with localized or regional cancers, very poor for patients with undifferentiated prostate cancer and any sort of spread outside the cancer capsule, and really no cure for metastatic disease. The life expectancy typically is 1 to 3 years, though some may live longer than that. So all of our different assessment tools will kind of give us our prognosis. The therapeutic orders level 1 and 2 can be supportive, but usually with prostate cancer itself, we're going to need to go to level 4 therapies. That's the primary approach. Now, active surveillance, I just want to say a little bit about that. This is appropriate for asymptomatic patients over 70 with low or intermediate risk of localized prostate cancer. Death is more likely in those patients from other causes than the prostate cancer. Here we're going to do maybe periodic PSAs and DREs to check for the doubling time of the PSA, etc. And then maybe periodic repeat biopsies, especially in younger males. But the treatment is initiated only if the cancer progresses, and that occurs in about 30% of overall patients. So this is becoming a kind of a main tool for prostate cancer assessment, is active surveillance. That's, again, different than just watchful waiting and just kind of not doing anything. We're actually doing testing here to see if the prostate cancer is growing and becoming more aggressive. So our different stages here, again, let's look at level 4 therapies. For localized cancer, this would be aimed at trying to cure the cancer, and that would be surgery, best for patients under 70 with localized tumors, and this would be a radical prostatectomy or cryotherapy of the prostate. Here, complications would include urinary incontinence, urethral stricture, erectile dysfunction, and any rectal injury from the damage to the nerves that innervate both the penis and the rectum. Radiation therapy would be sometimes used in conjunction with that, and that would be direct radiation or brachytherapy, where they put radioactive pellets inside the prostate to destroy any remaining prostate tissue, and then high-intensity focused ultrasound, not as commonly used in the States, but it's kind of emerging as a potential treatment tool there for localized prostate cancer. For systematic cancer, again, trying to limit the tumor spread, trying to aim that at palliation, but androgen deprivation, and that would be actual castration removal of the testes, but usually that's done through the gonadotropin releasing hormone agonists, the leuprolide, which I discussed in the previous videos, other anti-androgens, radiation therapy, and then maybe using bisphosphonates for bone pain, fractures, etc., from the tumor mets. There is a form of systemic prostate cancer called castrate-resistant prostate cancer.
And this is where there's increasing PSA despite lowering the androgens. So really, the cancer is no longer responding to anti-androgen therapy. And that's where maybe chemotherapy is used. But that's pretty much has a very, very poor prognosis. So what are some of the level 1, level 2 therapies that can be used to support patients with prostate cancer? The evidence is very sketchy. We don't know, and we're kind of guessing. Typically, all the things I mentioned for BPH reduction and whatnot would be indicated here. So I won't go through that again. In terms of level 2 therapies, this is where in Chinese medicine, for instance, doing appropriate pattern differentiation, looking at, again, possibly using herbs that maybe decrease the insulin resistance if that's an issue in a person. Using phytoandrogens is controversial. We have no real evidence whether or not that's beneficial or harmful. So, but that said, if there's evidence for the need of stimulant adaptogens, that could be a possibility and so forth. So, unfortunately, not a lot of information on using level 2 therapies in prostate cancer. But hopefully that gives you a little idea about how we can approach prostate cancer with the assessments, what we need to be on the lookout for, and then a general overview of the therapies. Okay, so that wraps it up for prostate disorders, for BPH, prostatitis, and prostate cancer.